fourth part, part D, I believe, of Chapter 3, increased intrathoracic pressure and the circulatory system. So what happens to the cardiocirculatory system when you only increase the pleural pressure without an increase in lung volume? So again, let's go over our VEN. Part A, we talked about the hypothetical situation where you're only increasing lung volume and its effects on the cardiovascular system. In Part B, we then talked about only a decrease in intrathoracic pressure and its effects on the cardiocirculatory system, and sort of modeled this as the Mueller maneuver. And again, if we're looking at the normal response to a normal inspiration, it would be more like a mini Mueller, because the Mueller maneuver is a very pronounced drop in intrathoracic pressure, but when you're generating a typical inspiratory breath, it's a small decrease in intrathoracic pressure. And then when you combine these effects, the effects on the cardiovascular system of the increased lung volume and the decrease in intrathoracic pressure, when you summate these, you get a spontaneous breath. Holy cow. So now what are we doing? Well, we're moving along, and we're going to talk about how simply increasing intrathoracic pressure affects the Guyton analysis, and this is like a Valsalva maneuver. Again, a Valsalva is an increase in intrathoracic pressure without an increased lung volume, and that occurs because you grunt or bear down against a closed glottis. So again, let's see how this affects the ventricles in turn. The increase in intrathoracic pressure without a change in lung volume causes the right ventricle to shrink in size, and this occurs despite a seemingly paradoxical increase in right atrial pressure. Again, this can be confusing to junior members of the intensive care unit team, and you can quiz them on this, because we tend to think in a very cardiologist-centric world, and they often, not all, tend to think in terms of a very Frank Starling-centric world, where you increase right atrial pressure, and when you increase right atrial pressure, well, then you're increasing stretch on the heart, and then if you increase stretch, then you increase output. Well, then how does increasing intrathoracic pressure with a Valsalva increase right atrial pressure, but actually decrease cardiac output? And that's because, well, it's because venous return is decreasing as a function of the increase in intrathoracic pressure. Upon initiation of an increase in intrathoracic pressure, the decrease in right ventricular volume results in a very brief, again, maybe in the first cardiac cycle or so, and again, this depends on how much the right ventricular volume decreases, which will be a function of the increase in intrathoracic pressure, as we'll see, but also the patient's baseline volume status. So as the right ventricular volume shrinks from the decrease in venous return with the increase in intrathoracic pressure, it briefly improves left ventricular compliance, and there may be a brief increase in your left ventricular and diastolic volume. So let's go to just the RV preload. Well, we talked about mini Mueller decreasing your intrathoracic pressure somewhat without increasing volume. Well, let's talk about a mini Valsalva. That's a small increase in intrathoracic pressure without an increase in volume. Again, to orient yourself, this is the Campbell analysis. Lung elastance, chest wall elastance or compliance, essentially airways resistance, volume, intrathoracic pressure in centimeters of water. But when we superimpose the Guyton analysis, we're now in millimeters of mercury. And this is your venous return curve, and this is your right ventricular cardiac function curve, we'll say. I've generically labeled it cardiac function curve, but blue is right ventricular. So again, this portion, the x-intercept of your cardiac function curve, follows the increase in intrathoracic pressure. You shift the right ventricular cardiac function curve rightwards along the venous return curve, again, because there's no change in lung volume. There's no change in your mean systemic pressure. There's no compression of the venous capacitance beds, and you simply shift the cardiac function curve rightwards, and you therefore cause a shrinkage of your right atrial and right ventricular transmural pressure. And you saw that venous return or blood flow is also decreased. And again, by similar reasoning that we talked about in the earlier portions of this chapter, that because there's a very small gradient for venous return, very small changes in intrathoracic pressure can lead to very abrupt changes, or very pronounced changes, maybe I should say, in venous return. Well, what about right ventricular afterload? Well, as described in the previous section, changes in right ventricular afterload occur only to an increase in intrathoracic pressure without an increase in lung volume. That will be to decrease the right ventricular afterload. So what does that mean? Well, remember we talked about, I think it was in part 2 of this chapter, that the afterload is modeled by the wall tension across the right ventricle during systole of the max wall tension, and that's modeled after the law of Laplace, and it's directly proportional to the radius of curvature and the transmural ventricular pressure. And so if you increase your intrathoracic pressure, well, you're going to decrease that radius of curvature, and you'll tend to decrease the tension on the right ventricular myocytes, and therefore you'll decrease afterload. There you go. That's what I just said. So other potential mechanisms for the decrease in right ventricular afterload with an increase in intrathoracic pressure. Again, this is negating any changes in lung volume because we're just talking about mini-Muellers at this point. You may have a decrease in your left ventricular end diastolic pressure via ventricular independence. Again, if you shrink RV volume, you then relax the LV by improving its compliance, and you therefore may drop its filling pressure. And again, the left ventricular end diastolic pressure is the ultimate back pressure for RV ejection. The decrease in right ventricular afterload via decreased left ventricular afterload and systolic interdependence. So, you know, the left ventricle helps the right ventricle contract, and it's quoted that, you know, the exact numbers, but maybe 40 to 60% of the systolic pressure that's generated by the right ventricle is actually generated by muscular contraction of the left ventricle. So in theory, if you increase intrathoracic pressure and you decrease left ventricular afterload, because you're decreasing the transmural wall stress of the left ventricle and aorta relative to the extrathoracic compartment, then you may facilitate unloading of the RV. And then a decrease in pulmonary arterial transmural pressure in excess of the right ventricular transmural pressure as a result of pericardial effects. Again, this is completely speculative, and that is the right ventricular myocytes and the pulmonary arterial smooth muscle cells, I guess you could say, do not entirely experience the same transmural pressure because of the pericardium, and the pericardium may actually kind of absorb some of that transmural pressure for the right ventricle, so there may actually be a greater drop in the transmural pressure of the pulmonary artery and the great vessels, which may, through hand waving arguments, if you decrease the transmural pressure, you may actually improve its compliance and therefore decrease its impedance. But again, that's totally speculative. So increased intrathoracic pressure in the right ventricular afterload. We're going to increase your intrathoracic pressure from point A at FRC to point B without a change in lung volume on the Campbell analysis. And then we're going to superimpose the Guyton analysis. So this now becomes right atrial pressure, blood flow on the y-axis, again pressure on the x. This juncture here represents atmospheric pressure, above atmosphere, below atmosphere. The pressure within the right atrium relative to the intrathoracic pressure is the transmural or distending pressure of the right atrium and the right ventricle. As you the x-intercept of the cardiac function curve, this portion of the right ventricular cardiac function curve, and by this portion I mean the x-intercept, this is the portion that tracks changes in intrathoracic pressure. So as the intrathoracic pressure increases along the Campbell analysis here, your cardiac function curve will shift rightwards accordingly. Comme ça. And cardiac output, or the operating point of the curve, will shift down and to the right. So your output of your right heart is decreased despite an increase in right atrial pressure, and the transmural pressure has shrunk. So in that situation, the right atrium and the right ventricle would tend to shrink. The decrease in right ventricular end diastolic volume tend to improve right ventricular ejection in terms of afterload effects. And this improved injection can be illustrated by a small increase in the cardiac function curve. And again, in health, this would be a very minimal effect, if at all. You can see that you know, with the increase in intrathoracic pressure, your starting point is a cardiac output way up here. So if your cardiac output is way up here, and you Valsalva, for instance, or just increase intrathoracic pressure, well, watch where your cardiac output ends. Well, you have a pretty abrupt drop, primarily as a drop in your preload, and then maybe this sort of theoretic small improvement in ejection may shift your cardiac function curve up and to the left only a small amount. It's still not going to overcome the drop in output that you get from the increase in intrathoracic pressure and the drop in preload itself. So what does this do to left ventricular preload? Well, the increase in intrathoracic pressure, or the pleural pressure, has conflicting effects upon the left ventricle, and this is also mirrored in the literature. Ultimately, the increased intrathoracic pressure tends to diminish LV preload. When the increase in pleural pressure coincides with diastole, there tends to be a brief increase in LV stroke volume. And again, this is very brief and very minor, and that is primarily a diastolic ventricular interdependence effect. If by chance the increase in pleural pressure tends to coincide with systole, there may be slightly improved ejection as a diminished left ventricular afterload is achieved, and therefore subsequent beats, if you imagine greater output from the LV, you would lower your end systolic volume, and then subsequent beats may therefore not demonstrate an increased LV volume. And again, these tend to be minimal changes in health. And as before, the left atrial pressure will increase relative to atmospheric pressure when intrathoracic pressure increases, but the pulmonary veins are exposed to the same intrathoracic pressure, so the LV curve and the pulmonary venous return curve will shift in tandem as a result of just the changes in intrathoracic pressure. But I don't demonstrate this for simplicity. Demonstrating some of the conflicting effects on the left ventricular preload and increased intrathoracic pressure, because there's these conflicting physiologies. Again, just for repetition's sake, we're increasing intrathoracic pressure without increasing lung volume, and I'm going to call this a mini Valsalva. There's an immediate decrease in right ventricular volume, despite an increase in right ventricular or right atrial pressure, as I'll demonstrate. As you can see, transmural pressure has shrunk, therefore the volume of the right atrium and right ventricle will tend to shrink. Output is diminished. Okay, well, let's superimpose the left ventricular cardiac function curve and see what happens. The drop in right ventricular volume may result in a brief, probably 1 to 2 cardiac cycle improvement in left ventricular compliance. So your LV curve may shift up and to the left a bit, so there might be a small improvement in outflow at a lower pressure. And this brief improvement in LV compliance tends to occur if the increase in intrathoracic pressure predominates during diastole. And again, that was from ventricular interdependence effects. And sometimes you'll see this in studies when you read them. It's like 50% of the time, left ventricular end systolic volume and end diastolic volume decreased, and 50% of the time left ventricular end diastolic volume increased. And this is, probably and fairly well described by Scharf in a number of his reviews, probably just due to random chance of when the most prominent change in intrathoracic pressure, when the intrathoracic pressure increases the greatest, whether or not that's occurring predominantly during systole or diastole. And again, probably fairly minimal transient stresses upon the cardiovascular system. Moving on to left ventricular afterload, increase in intrathoracic pressure. Again, tends to facilitate ejection by the LV, but small increases in intrathoracic pressure can have very minimal changes in the left ventricular transmural pressure. This tends to improve the cardiac function curve as the increase in intrathoracic pressure decreases this transmural wall stress. And then just to re-demonstrate this, that's your mini Valsalva. The right ventricular cardiac function curve shifts rightwards. And as we talked about, the drop in right ventricular volume by ventricular interdependence effects tends to temporarily or transiently improve left ventricular compliance. And then with this decrease in LV afterload, there may be a further shift up into the left of your LV function curve and have a very small effect on left ventricular output. You can tell because the slope of this line is so great in the normal cardiac function curve that increasing the slope a little bit more has very minimal changes in your output. So just these last couple of slides, I'm going to do a very brief overview of the Valsalva maneuver. Again, what I talked about in the previous slides is really, they were kind of like, as I'm kind of glibly saying, mini Valsalvas. A real Valsalva, if you read the literature on a Valsalva maneuver, it's a very specific procedure that's prolonged, 10 seconds long or so, and it's usually a very dramatic increase in intrathoracic pressure, which is quite pronounced. And variability in the cardiovascular response to Valsalva in various papers can arise from multiple mechanisms, and it's somewhat similar to the Mueller, as I talked about a couple sections ago in this chapter. The baseline volume and rate of the pre-strain breath, the degree and rate of the strain itself, changes in lung volume. If there really shouldn't be if you're doing the Valsalva correctly, the duration of the strain period, the depth and the rate of the post-strain breathing, etc. But I don't really want this to become an exhaustive explanation for Valsalva. But the pattern of response does highlight some of the physiology that we just discussed. And this physiology that we just discussed, again, helps dissociate the effects of intrathoracic pressure on the cardiovascular system from volume effects. So if this is your heart, right ventricle, left ventricle, this arrow represents systemic venous return, this arrow represents pulmonary venous return, and this is your pericardium, and this is your interventricular septum. So at the onset of a Valsalva, as we saw, the right ventricular cardiac function curve shifts rightward relative to the systemic venous return curve, and you diminish venous return. So the smaller volume in the right ventricle I've kind of depicted this by this change in the interventricular septum. It probably doesn't really change like this all that much. It's more of just an improvement of the overall LV compliance. The improved LV compliance would tend to increase your left ventricular end diastolic volume at a lower left ventricular end diastolic pressure. So this results in a very brief increase in left ventricular stroke volume, increased arterial pressure. A lot of this arterial pressure with the Valsalva actually is probably diminished or transmitted intrathoracic pressure directly to the intrathoracic aorta. But there is some evidence with radionucleotide gating in healthy volunteers when you Valsalva. There is an increase in counts in your left ventricle immediately, and so there probably is a very brief transient increase in your left ventricular end diastolic volume, and this will be the phase 1 of the Valsalva maneuver response that you may see in the literature. So that diminished venous return with the initiation of Valsalva, then after a few cardiac cycles makes its way down to pulmonary venous return, and left ventricular venous return starts to decrease. And again, this starts to occur when the Valsalva occurs over a period of prolonged seconds. This isn't like a short, like you may have with a mechanical ventilator, increase in intrathoracic pressure. But as it's maintained over many beats, you start to have diminished left ventricular venous return. And then you have a prolonged and prominent decrease in left ventricular stroke volume as a function of this diminished right heart return making its way to the left heart. And then you have a decreased arterial pressure. You have a decreased arterial pulse pressure suggesting lower left ventricular stroke volume. And this is this prolonged phase 2. Then you suddenly release Valsalva, and as you have now you have a very rapid and pronounced decrease in your intrathoracic pressure as you release the strain. And then you kind of bolus the right heart again, which then may temporarily diminish a left heart output. Additionally, this may have a bit of an afterload effect on the left ventricle, so you kind of suddenly, very quickly, abruptly increase the left ventricular afterload. And there's certainly also a component of the direct transmission of the intrathoracic pressure to the aorta. And this results in a very short phase 3 phenomenon where your pressure and output drops even more, but temporarily. And then just a couple of cardiac cycles later, as this increase in venous return makes its way to the left heart, you then increase your left ventricular stroke volume. There's increased arterial pressure, and some call this the overshoot phase, where you then have an increase in your arterial or your aortic pressure and stroke volume, and then you return back to baseline. So that's a very brief overview of the Valsalva. Maybe it's a little bit of a digression from the overall theme of this chapter, but you will come across Valsalva in papers and the different phases, and the different phases do reflect to a certain extent a lot of the physiology that we talk about in this chapter, so I thought it was worthwhile throwing that slide in. And that was it for part D. And now we're going to move on to intermittent positive pressure ventilation, which, as you can already guess, is the addition of increased lung volume to the increased intrathoracic pressure physiology that we just talked about.